This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Clinical Neurology and Neurosurgery, published in 2026, regarding a perennially challenging topic in our field, idiopathic normal pressure hydrocephalus, or iNPH.
It really is one of the great masqueraders in neurosurgery, isn't it? We know the classic triad: gait disturbance, cognitive decline, and urinary incontinence, but the real clinical headache is predicting who actually gets better after we place a shunt. Specifically, predicting dementia recovery is notoriously difficult compared to gait.
Exactly, and that's what this study tackles head-on. The researchers wanted to determine the most appropriate assessment scale and the optimal timing of the TAP test, the TT, for predicting improvements in dementia severity after shunt surgery.
For our residents listening, the TAP test is our standard preoperative maneuver, removing 30 milliliters of CSF, but the timing of the post-TAP assessment is often debated. Ilara, walk us through the methodology they used.
It was a prospective study involving 71 patients diagnosed with iNPH. They followed these patients for 12 months after they received either a ventriculoperitoneal or lumboperitoneal shunt. To measure improvement, they used the Clinical Dementia Rating, or CDR. If a patient's CDR score decreased at the 12-month mark, they were classified as an improver.
And they didn't just use the standard mini mental state exam, or MMSE, right?
Right. They compared 3 different scales: the MMSE, the Frontal Assessment Battery, FAB, and the Addenbrooke's Cognitive Examination 3, ACE3. They performed these assessments at baseline, then again at 1 day and 4 days after the TAP test.
That 4-day mark is interesting. Often in clinic, we see patients a day after the TAP, and if they haven't cleared up, we might be pessimistic. What did the baseline data show?
Even before the TAP test, there were differences. The improvers, those who eventually got better after the shunt, had significantly higher baseline scores on the MMSE, FAB, and ACE3 compared to the non-improvers. It suggests that patients with less severe cognitive baseline impairment might have a better regenerative capacity, so to speak.
That aligns with what we see in practice. If the dementia is too far gone, a shunt might not be a magic wand. But let's get into the TAP test results. This is where the paper gets really specific.
This is the core of the study. They found that improvements in both the MMSE and the ACE3 at day 1 and day 4 were significantly higher in the improver group. However, when they ran the ROC analysis, the receiver operating characteristic, the ACE3 was the clear winner. It showed the highest area under the curve, or AUC, for predicting long-term success.
So the ACE3 outperformed the standard MMSE. Why do the authors think that is?
The ACE3 is more comprehensive. While the MMSE is a quick screen, the ACE3 covers more ground and seems more sensitive to the specific frontal subcortical changes we see in iNPH. But the most critical finding was the timing and the specific score increase.
Tell us about that magic number they found.
The study found that an increase of 6 points or more on the ACE3 at day 4 after the TAP test was the superior predictor. It had a sensitivity of 81.3% and a staggering specificity of 94.7%. The AUC was 0.899.
94.7% specificity? That's incredibly high for a clinical predictor in hydrocephalus. It means if you see that 6-point jump on day 4, you can be very confident that a shunt will actually move the needle on their dementia severity.
Exactly. And the fact that day 4 was more predictive than day 1 is a huge takeaway for residents. If you only test the patient 24 hours after the TAP and don't see a change, you might be missing the delayed responders who show their true improvement a few days later.
It's a great reminder that CSF dynamics and brain compliance don't always reset instantly. So to summarize for our colleagues, if you're evaluating a suspected iNPH patient, don't just rely on a quick MMSE the next morning.
Right. Use the ACE3 and, if possible, track them out to day 4. That 6-point improvement is your green light for surgery.
Excellent. It's studies like this that help us move away from gut feelings and towards objective, data-driven surgical indications. That's all the time we have for today.
Thank you for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.
Stay sharp.